So we're going to just briefly discuss the 4-month regimen for which CDC guidelines were published recently. I don't have any conflicts to disclose. So as you guys will remember, in May of last year, the results of study 31, which was a joint study by the TB Trials Consortium of the CDC and the AIDS Clinical Trials Group of NIH, they published the results of their study that compared 3 different regimens. And you know, this study is an important study because it's potentially shortened the treatment duration for the treatment of pulmonary TB from 6 months down to 4 months. So in this trial, they compared 3 different regimens, one of which is our standard rifampin, INH, pyrazinamide, and ethambutol, RIPE, which is given for 26 weeks, with the first 8 weeks being all 4 drugs and the remaining time being just rifampin and isoniazid. They compared it to a regimen that's switched out the rifampin and replaced it with high-dose rifapentine, so 1,200 milligrams daily of rifapentine, all 4 drugs given for the first 8 weeks, and just rifapentine and INH given for the last 9 weeks. And you know, rifapentine is related to rifampin. It's a rifamycin, but it has a much longer half-life. And then the third regimen was looking at switching out rifampin for rifapentine again, but then replacing the ethambutol with moxifloxacin, a fluoroquinolone that's highly active against MTB. And in this regimen, 3 drugs were continued for the entire 4-month duration. Now, in the study, it included participants who were 12 years of age or older, had pulmonary TB that should have been smear positive, and that was susceptible to the key drugs in the regimen, INH, rifampin. But typically, if you have rifampin resistance, you're going to have sensitivity. You're going to have rifapentine sensitivity, and it was also susceptible to fluoroquinolone. HIV positive patients were eligible if their CD4 counts were greater than 100 and they were on an efavirenz-based regimen. Enrollment was, multinational in 13 different countries, with most of the patients being enrolled outside the United States. And they included any pregnant patients, patients who had been on 5 days of treatment with any of the study drugs in the prior 30 days. And that includes a fluoroquinolone. So that's an important thing to remember. Fluoroquinolones are widely prescribed. Or patients that had a long QT, meaning that there was a prolongation in part of the conduction in the heart. The concern there being that fluoroquinolones can worsen or lengthen the duration of the QT, which can put you at risk for arrhythmias that can be potentially fatal. Dosing was given 7 days a week, with Monday through Friday being DOT. So the primary outcome was survival-free of TB at 12 months, and secondary outcome was 18-month status. There were over 2,000 participants. And what you can see here, so here is, if you're on this side, your standard RIPE regimen is better. If you're on this side, the experimental regimen is better. And this is the non-inferiority line. So if you don't cross that, you can't say that a regimen is not inferior to the control. Sorry. So yes. So let's look at this one first. This is just the rifapentine arm without the fluoroquinolone. And you can see intention to treat, meaning that you randomize someone to a treatment. Microbiologically eligible, meaning that they were smear positive and that they were culture positive, and that their isolates were susceptible to INH, rifampin, or a fluoroquinolone. And here's accessible. That means they could be followed at those important endpoints of 12 months and 18 months. So you see, the regimen in which they just switched out the rifapentine actually was non-inferior for 2 of those different groups. But when you looked at the accessible group, you could not say that it was non-inferior, because this line does not cross this non-inferiority line. On the other hand, the regimen that contained both rifapentine and moxifloxacin, for all 3 different groups, we see that there's non-inferiority. As an aside, you can see that the point estimate, the center point of your estimate, always tended to be, or always was, on the right better arm. So while it met non-inferiority, you know, it suggests that maybe RIPE did treat the patients better. So CDC issued these recommendations in February. And the recommendation was for the rifapentine and moxifloxacin arm with INH and PZA. Again, 8 weeks for the first 4 drugs and 9 weeks for rifapentine, INH, and moxifloxacin. The eligibility was like the study. So you have to be older than 12 years of age, weigh more than 40 kilograms. It should be pulmonary TB that is susceptible to INH, rifampin, and fluoroquinolone. If HIV positive, then your CD4 count should be greater than 100, and receiving or planning to receive an efavirenz-based regimen, which is not necessarily first-line treatment for HIV in the United States. Not recommended in pregnancy or breastfeeding, prolonged QT, or use of QT prolonging medications, because many medications will prolong the duration of the QT in patients. And the more medications that you have that will do that, the higher the risk of arrhythmias. And again, it's not generally recommended for extrapulmonary TB because that was not studied in study 31. But it will probably work, especially in paucibacillary forms. So non-life-threatening forms. If someone just has, you know, TB lymphadenitis, some draining cervical lymph node, the shorter regimen is probably appropriate. Is it appropriate in someone with TB meningitis? Not at all, not at this point at least. Dosing should be 7 days a week, and food improves the absorption of rifapentine. That's how it was given in the study. So the medications should be given with food. Here you can see the doses at the top. They also recommend baseline molecular drug susceptibility testing for rapid identification of mutations associated with resistance to INH, rifampin, or moxifloxacin. And that should be followed up with phenotypic drug susceptibility testing. Now, of note, again, they don't insist on rifapentine, but they specifically say moxifloxacin. You've probably seen, you know, until recently in our state, ofloxacin was the drug that was tested for fluoroquinolone susceptibility. We are in the process or have added levofloxacin and moxifloxacin, but even between levofloxacin and moxifloxacin, you will occasionally see susceptibility with one and resistance to another. The treatment duration is independent of cavitations. 75% of the patients had cavitations in the study. 40% of the patients had cavitations greater than 4 centimeters in size. And 99% of the patients were smear positive. So in general, these were patients that had a high burden of TB in their lungs. How quickly do you have to complete this regimen? So the regimen is complete when 119 doses are taken. That is the 17 weeks. So the intensive phase, that first 8 weeks, 56 days, needs to be taken within 70 days. And the next 9 weeks, 9 times 7 is 63. 63 days needs to be taken within 84 days. So, you know, I think this is, we're going to see more of this, right? It's good for programs, it's good for patients. But some things to just keep in mind or to points for discussion. Well, first off, we have a rifapentine shortage right now, as we just heard from Lana. So unless we can ensure a steady supply of the drug, you don't want to start someone on the regimen. Next up, the drug susceptibility testing, not only for INH and rifampin, and they again are recommending both rapid and phenotypic, but for moxifloxacin. And so if we have anyone from the state lab about the status of that, both rapid and or phenotypic testing, we'd love to hear from you. As I noted, moxifloxacin may prolong the QT interval. In this study, 1 patient in the moxifloxacin arm out of 730 patients was thought to have QT prolongation due to moxifloxacin. So in general, it is rare, but it's more common when you administer it with other QT prolonging drugs, including some antiarrhythmics of the heart like quinidine, procainamide, amiodarone, sotalol. Those are all used for dysrhythmias. Ziprasidone or terfenadine. That's what it's, you know, I think it's said in their recommendations, but other drugs that also are at high risk for QT prolongation include methadone, bedaquiline, chlorpromazine, or haloperidol, so your antipsychotics as well. If you have a patient who you're thinking about starting this in, are you obligated to obtain an EKG if it's a low-risk patient? What if they're at high risk? Should you be obtaining an EKG? Should you be putting them on this regimen at all? And as one way of easily obtaining a QT estimation, we have things like this, the CardioMonitor, which is hooked up, that's basically a cell phone, and you just subscribe to it, and you have the patient place their fingers on these pads. I'd be interested in knowing if any programs out there are using this or other innovative methods for assessing a patient's QT. But